Kia ora koutou, nau mai, haere mai ki te wānanga ako. Ko Rachel Tokuna, I'm Rachel and I'll be your host for tonight, just this part of it. Before I hand you over to all our speakers, a little bit of housekeeping. The meeting will be recorded and it will be sent to everyone who registered. And to those of you online, just if you have any questions, put them in the chat or in the Q&A section and we'll get to those at the end. So I'll do a quick karakia and then I will hand you over to Leonard, who will be introducing everybody else and why we are here tonight. Puritia mai rā te tika he kōrero, puritia mai rā te pono he wānanga, puritia mai rā te aroha he āwhina I te nāko a tangata. Kia atu, kia atia, kia marama, huie, tai kie. Kia ora, Leonard. Stage is yours.
Hi everyone, my name is Leonard. I'm from Home Support North. We're really excited to welcome everyone here tonight. We obviously are very passionate about this subject, and Alenka from our team put this evening together. Unfortunately, isn't able to be here, but we're taking this in her stead. So welcome. What I'd like to do is just take you quickly through the speakers and presentations for this evening, and then the objectives, and then we'll drop right into it. So we have Gay, who's going to talk to us about dementia from Dementia Northland. Or did I jump back? Sorry. We have Jen and Anne from NASC, who are going to talk to us about that process. And then I'll talk a little bit about what we do at Home Support. We have Satish from Northable, who will talk to us about that element of the process. And then Omar from Unichem Pharmacy, who will talk to us about their side of the process. And the idea at the end of this is that there's an overall picture of what the journey looks like, particularly for a dementia referral in our system. We have defined 3 objectives as part of the CCE component of tonight, and they are to identify the key factors contributing to successful independent living for older adults, especially obviously those with dementia, to be able to describe the whole process for accessing home support services, and including navigating the NASC system, which I won't say anything about. It's not that difficult, but Jen and them will tell us all about it. And then also to be able to explain the roles of various healthcare professionals and the support organizations in that journey. And then at the end of it, there'll be an opportunity to answer any questions that you might have. And then like we've been told, please help yourselves if you want anything to drink or eat along the way. So I'll just slip into this first slide because this is really the key or crux of why we've organized this. So as we all know, the population in New Zealand is aging at increased rates. And one of the things that happens in our aging population is the presence of things like dementia and the treatment that's required from that. So we see that a lot from a home support point of view, and that's why we suggested that this would be the theme for this evening. So I'm going to hand over to you, and you'll tell us all about the process of understanding it and its impact on people.
Right. Hi, I'm Gay Chaplin from Alzheimer's Northland, and basically we're here to, I'm here to explain the dementia side of the journey. So we all know that there's 100+ different types of dementia, and it's probably easier just to go through the first few. So the first few are Alzheimer's is the most common, accounting for 65%. And then you have vascular dementia, Lewy body and frontal temporal. And those are the most common ones that we see. So on top of these 4, recently I've found with some of my clients that I'm seeing Korsakoff show up a lot more, and that's an alcohol-related dementia, and I'm seeing it in the earlier ages, so like 55 to 65. So one of the things about this journey for my clients is that my clients can put on a good show for 15 minutes when they go and see their doctor or when they see their children or something. So we need to get a better understanding of what's really going on in the family and the home situation. So when we go and see our clients, our initial visit takes about an hour and a half. And it's so we can monitor their changes and in the answering of the questions and things like that. So to start with, they might be really happy and easily answer the questions, but by the end they've got tired and they're starting to slip up, and finding words and things like that gets harder. So with the cognitive changes that are in our clients, there's a lot of confusion, not being able to find words and things like that. And those are the most common things that show up in our clients. And they're probably the things that show up the first. And most of the families can see it happening and things like that. So we rely a lot on the family to get the full picture, because our clients will probably tell us, I don't know. Our clients, oh, there you go, those are the, I forgot about this bit, sorry. So yeah, confusion. Our clients will tell us that there's nothing wrong with them. So when we get our referrals, if it's just got their name on it and we ring them up and we say we've got this referral, I go, there's nothing wrong with me, I don't want to talk to you, hang up. So that's something I'll talk about a little bit towards the end. But yeah, we get all sorts of things, completing familiar tasks, like a coffee. We all make coffee or tea. And we do that every day and don't think anything of it. But it's actually got a lot of steps. You've got to get the cup out, you've got to fill up the jug, you've got to turn the jug on, you've got to get the teaspoon out, the coffee, the sugar, the milk. Which way do you put it in? Which vessel do you put it into? And I used to find with my own mother, she would pour the jug and then she'd pour the water into the actual coffee container. So you've got a whole coffee container gone in one sitting, sort of thing. So it's those sort of things that we're noticing with our clients. Tasks that we think are simple get quite complicated, and it has an effect on the whole family. And it's frustrating for our clients because they know that they used to be able to do all this stuff. They could work 40 hours, 60 hours a week and still come home and do everything, and now they can't. So they get frustrated, and when they get frustrated, then other things start to happen, like the anger and the agitation and things like that. So those are the things that our families see. They see, oh, mum's getting grumpy or mum's getting agitated. But if you look behind that, you'll see that mum's just frustrated because no one's listening to her, no one's believing her, and that sort of thing. So this is the sort of changes that we're finding. We always explain in our first initial visit that it's actually a progressive decline. So what we're saying to our clients is we expect it to decline slowly. So it should be coming down, and you will see it decline as the family member, perhaps, oh, mum used to do that 3 weeks, 4 weeks ago, a month ago, but she can't do it now. If there's a big drop, then that's medical, that's something else. We need to see the GP. So it's becoming more obvious in our older generation because we are living longer, and we're seeing more of it. So whereas a lot of people never used to know about dementia, so I grew up in the 70s and dementia was never spoken about, and it was just, oh yeah, well that's funny old Aunt Amy, leave her, we'll just ignore it. Now we want everyone to know about it, accept it as part of ageing, and get some education out there to understand it. So getting a diagnosis is a huge part for us, because to to start with, need to understand what's going on. So if we can rule out a UTI or an infection, and that's going to the doctor, let's rule out that to start with and see what we're dealing with. And then what happens is, even at the mild cognitive impairment stage, if we can get involved then, we start setting the family up to understand into what's going to happen, what could happen in the future, what's going to change, how mum or dad is going to change and how to cope with those changes. So the earlier we can get involved, the better. We can then discuss with the family, okay, so we're going to have to perhaps talk to NASC and get some funding for some supports to be put in place. What do those supports look like? Well, that involves, you know, Access Geneva, Northland support, home support, those sort of places. So we explain all that to our clients, and we talk about power of attorney and wills. So it's giving the family a chance at that early stage, while our clients are still cognitive enough to make these decisions, to organise the rest of their life. So, and plan for their future, basically. So that's what we want. We want to get in as early as we can so that we can help the family as much as we can. And even if at the beginning, it's just for advice and support and perhaps some carer support, so that if mum needs to go and do something, someone else can look after dad. But to get that, we still need our NASC referral. So it's just to get the doctors and our professional people to get in there a little bit earlier, make a decision, give us a referral. You know, that could be the first step, just refer to us, and then we can start the process rolling. So that's basically what it's about. And so yeah, the early diagnosis gives us time to educate the client's family more than the client. So it's all about the family, so the mum, the dad, the children, the grandchildren, and I spend quite a bit of time with the extended family, so that our clients, it's very good for them to socialise and socialise with all the different age groups. So I try and involve the whole family in the process. But lots of things change. And one of the things I was going to say, and it's quite embarrassing for some of the clients, is the sexual behaviours can change, and they don't like talking about it because it's a taboo subject. But this can cause a lot of stress and anxiety for the clients. So it is something we need to be prepared to discuss, things that we're not exactly comfortable with discussing, but that's just how it goes. So basically it's just about giving the family time to understand and just do a bit of research or ask a few questions about it. So early diagnosis is something that we're very keen on promoting, so we can get into help as soon as possible. And on that note, the ladies from NASC are going to come up, I think, and tell us about NASC referrals.
Hi everyone. I'm Jenny and I'm Anne-Marie from the Needs Assessment team in for Northland. So I'm the clinical nurse manager and Anne-Marie is triage coordinator. Lots of experience in NASC, and that's why we both come together. So long story short, we'll be quite quick. I talk quite fast, so please slow me down if need be. I'm not sure if this is when you can ask questions, but please feel free to ask questions, because 9 times out of 10 people have 1,000 questions for us. So please do if you do have some questions. So basically, we're just going to briefly go over what we do, and then we can get into a bit more of the nitty-gritty stuff if we want to really have a chat about our dementia clients and things like that. So that's cool. So long story short, we are NASC, that stands for Needs Assessment and Service Coordination. Very long-winded name, and 9 times out of 10 clients don't know what the heck we do, and I don't blame them, it's a funny name. But basically, we're a gateway to funded services for Health NZ within Northland. That kind of makes sense. And so in the way we connect with clients and find out about clients is referrals from all sorts of people. So obviously GP practices, health professionals in various places, clients can self-refer if they're known to us, so existing clients can self-refer, and things like that. Have I missed anything about this? No. One of the reasons for that is obviously, no doubt everyone's heard about the NASC waitlist. We're a very hot topic about the NASC waitlist. We do have a waitlist. That we will always have a waitlist because of the amount of clients we have to service and the length of assessments. That's a reality. And so we have to prioritise, and we have to be quite brutal when we prioritise. And so the more information we have on referrals, we can prioritise. If we don't get that information, what we've read might be very not that urgent, not that needed, and we will waitlist if we don't get that information. So just to kind of put that in concept.
And it's probably worth mentioning that we do take 30 to 40 referrals per day for needs assessment.
Which does exclude phone calls of clients calling. Okay, so it's a lot. We have 3 people in triage, one Emery's one of them, but 3 all day, every day, just triaging our referrals, and just to put that in perspective. So it is a big, yeah, it's a big service. And so, yeah, like I said, we need the information. So we do ask that the first referral comes from a GP or a health practitioner, hospital, various things like that, because we need that information and that medical understanding of what's going on to really be able to prioritise. Definitely, we're happy for clients, family, whānau to call us. Absolutely, if they're not known to us and they just want to understand how they get hold of us, what they do, what they need to do. Absolutely, but to take an extra referral will be the first one, say health professional, if that makes sense. We are over 65 NASC, because there is a Northable NASC, so people can sometimes get that a bit confused. We're over 65 and we're Health NZ, but we also do long-term chronic health clients. So they're clients between the ages of 55 and 65 with long-term chronic health conditions. So Northable, I'm not Northable, but just to put it in perspective, disability, we're not disability, we're age-related, we're chronic health conditions, if that kind of just understands that point of view. Please feel free, if I'm not making sense, and just yell out and interrupt me. So that's cool. Another thing to put in mind, you'll see there, we do acute home supports too. That sits under NASC, but they're acute home supports. So if someone comes into hospital, they've never met us before, they've never had support, and they've had a pneumonia or something, and they need support when they first get out of hospital, that's us. So we'll put that in. We won't do an assessment, we just put those supports in based on what we've read in the ward notes, the conversations with the nurses on the ward, and various things like that. Or it might be someone that's going through treatment or something like that we need to support them while they're going through treatment. And another big one for us is our palatable terminal clients. And that's where we would do our acute home supports for them in that sense. So that's kind of just in a nutshell what we do to some degree. Let's see if I can figure this bad boy out. Okay. So this is just some of the things we do.
That's predominantly what we're a gateway for.
Yeah.
So we're a gateway for home and community services, care support subsidy, although we're not the only people who can allocate care support. Hospice can, and so can GPs under personal health reasons. So if, they don't always have to wait for our wait list to have that allocated.
Yeah. And my understanding, I don't think everyone is aware of that factor, so it's just to bear in mind. Once a client is known to us, we will then take over and we will look at the renewals. But if someone's not known to us, or for example, hasn't had a long-term assessment because they're under the acute home supports, a GP or hospice can allocate that care support, because we may not need to get involved from a long-term perspective at any stage, if that kind of makes sense. So if you've got any questions, feel free to ask about that stuff.
So we're always also the gateway to respite, in that is we have a managed respite bed program, which is for a higher end clients, where we manage it. The beds are set in certain rest homes and people rotate through a bed. So they'll be at home for 2 weeks, in care for 2 weeks, home for 6, back in. So it rotates, it gives those really high end clients, their carers, a really good break.
And just to put that into, so obviously there's a wait list for that, because we have a wait list, but a lot better wait list these days, that just FYI. But yeah, and so it is one, in the respite program, the one thing I'd say with that, so we would have to do an assessment, they would have to have high or very high needs. It's not just in the nicest sense. We have to look at that and prioritise once again. But it is for those, and it doesn't work for everyone, because some clients or family and whānau, they don't want that regular scheduled respite. It doesn't work for them. They just want to have a one-off respite, or they just want to, or something like that, or perhaps it's what we've got available isn't available where they want to be. So it's just to understand there is a wait list, but there's also people that don't want to be on the wait list. And so that's where your carer support comes into play, because we might say, what might work better for you is just using your carer support, because you can choose where you want to go, when you want to go, versus a regular respite that you're going to be going in and out of every 6 weeks, if that kind of makes sense. So
And of course, carer support gives them the versatility of being able to have family members provide the relief they need, or friends. It doesn't have to be within residential care. So there are those options and versatility around carer support.
That's right. And just while we're talking about carer support, might as well stick to the same topic. But the carer support with our clients, and I guess we're talking about clients suffering from dementia and various things like that. So if someone does have carer support and they are suffering from dementia, we will likely have looked at whether they need a level of care if they're going to go into a facility to use that carer support. Okay, so anyone that might need to enter, we can touch on this when we go to permanent residential care, but anyone entering a residential facility that might need a secure environment, such as a secure dementia level of care, we must have confirmed that level of care. Okay, so no, and it's just really good for people to know, because sometimes it is really confusing, and you can kind of understand it, but we would have sent that information and talked to the client and the carer about that. But it's just, if someone is looking at respite, going into a residential facility, and we know they've got a diagnosis of dementia, reach out to us and just say, hey, what's happened? Is there a level of care? Where's the best place they should be going? And we're more than happy to help, or tell the clients or family or whānau to call us if they're a little bit muddled about the process. But just to kind of put that in perspective, especially those ones with dementia, or especially those ones at risk of wandering or being intrusive when you're in the facility. So that's carer support. What else are we doing, right?
We do daycare, which of course Alzheimer's provide as well, but with this, daycare. So there's the Alzheimer's Day Centre, and then there are social day centres as well. So I guess the other big thing we do is we're a gateway to permanent residential care. So it's a NASC role to determine that somebody, first of all, meets the criteria for age-related residential care.
Because there is a criteria.
And there is a criteria. And it's worth mentioning that criteria, because I think gone are the days where going into residential care is a choice for people. It has to be a need, and it has to be a relatively high need. So part of the criteria for long-term residential care these days is that this person cannot be supported in the community, so that we cannot provide enough support that will keep them safe at home. Yeah, it's kind of a biggie. And so it's NAS's job to, number one, determine that they meet the criteria for residential care. It's then our job to determine what that level of care is. And there are 4 levels of care. There's rest home level care, dementia level care, which they call like stage 3 residential care, hospital level, and then what they call psychogeriatric level of care. You might have heard it called D6, which are for your significant dementias who have significant behaviour issues and need that higher level. And so we will, and with those clients we do in conjunction with the POTS team, determine that level of care. And of course our dementia level care is one that are more rest home level, just needing a bit of security. Those D3 dementia level cares we do in conjunction with our geriatricians. Yeah.
Excellent. Yeah. And I mean, if you've got any questions about what that looks like, because obviously because the funding of residential care can be quite confusing, and it's just really good to be mindful. It does impact our clients. It is at their, in the nicest sense, it's going to cost them to go into care. So that's why it has got to be their decision. It's got to be their family and whānau's decision if the EPOA and various things are activated, because we're not funding that care in the nicest sense. So it's just being mindful of that.
And I guess it's possibly, when we're talking about residential care here, that when we are talking about those secure levels, that dementia or psychogeriatric level of care, that there are some legal requirements around enduring powers of attorney or triple P, that sort of thing. We cannot just put somebody into that secure level of care without that formal paperwork, diagnosis, activations, and all those sort of things. And I know that a lot of GPs find us quite annoying about what we ask for sometimes, but it is a legal requirement and we don't have a choice.
Yeah. So, yeah, and we will ask a lot about capacity, and that's not about please go and, the interpretation is not about please go and activate the EPOA so they can put them into care. It is about, does the client understand what's happening to them and have the ability to make decisions? That's what we're needing to know. And then it's about that EPOA and various sides like that. And we do get a lot of those all the time. And I mean, a good example today at the top of my head, I mean, I've received a referral today because there's a client at home that's, you know, got a lot going on, but the reason we got the referral is because they're demanding and not listening and telling people to go away. That's my referral. That's our referral. And they're asking us to put them into residential care. So as you can appreciate, I can't do anything with that. So one, where's the capacity? I can't see any history about cognitive impairment, dementia. Does the client want to go? What's happening? So it's all those things. So it's just to put that into, if we get something like that, we've got so many other things to look at, and that's when we're going to come back and ask a lot more questions.
Yeah, because quite often our referrals will say that you've had GPs will have had a discussion with family members, and family members feel that it's time this person went into care. The reality is, unless they're deemed not to have capacity, if they still have capacity of some description, it is still their choice whether they go. And we do spend a lot of time, I think, going through Apple's rights around that sometimes, which gets us into a bit of trouble too. But and of course, as you know, with dementia, there's degrees of, and so to actually deem somebody incompetent, you've got to be that far down the track. And you know, even competent people might make bad decisions and have a right to risk. And sometimes people who aren't quite there as incapacitated have a right to live at home with some risk involved.
Yeah. Absolutely. So as you can see, residential care is quite a big topic and quite a lot to talk about, and so can't get it covered all in this time. But I guess we're just reaching out if there is questions, if you've got clients or family in whānau, then please just give us a call and we can go through that type of situation. So cool. The other thing is, so obviously, like we mentioned, we deal with palliative and our terminal clients. I guess that's as much as it. We provide supports. We help support them in what they wanting to do and what's working for them. But that's not basically that covers that. And we do have an option for supervision hours in home. Probably not a separate thing. That's really just part of one of the packages of care. But supervision is a criteria. And so our biggest advice for supervision hours, which basically means someone goes in and sits with someone who might be suffering from dementia and they're really at risk of wandering or looking for their loved one or anything like that, we may allocate someone to go in and sit in there for so many hours. But the biggest thing would be for us is there is a criteria. It doesn't get allocated to every client that has dementia. It's about those behaviours and those risks and how much hands-on input is someone's needing to do for that person. So just to bear that in mind. But absolutely, we do have options. And I think the biggest thing to understand when we do our assessment, and when we do an assessment, which you probably haven't really touched on because it's it's an assessment, but just to let you know, it's the inter-assessment. So it's a mandated assessment that we have to do. All of the New Zealand NASCs have to do it, over 65 NASCs. And so it's a it's a thorough tool. I mean, it is a good tool, but it's a lot. And I think at the top of my head, and I don't want to tell you wrong, I want to tell you that it's 22 pages, but I could be.
I think it's something like 237 questions.
Yeah, so it's a lot. And so that is actually a day's work. So it's a lot of information that we're pulling and we're talking to people about. So I guess the biggest thing is when we get a referral, and I might say, please do this, whatever, that's fine, that's cool. But it's just bear in mind, just trust the fact that we will look at everything. We won't just look at that topic. When we look at someone, we're looking at everything. So if we look at someone, we can see there's significant carer stress. We're going to be looking about carer support. If we look at someone that's no longer mobile, and we're getting at risk of pressure areas, we're going to refer and communicate with the occupational therapists and various things like that. So it's just, we will look at everything. The other thing to bear in mind with all our referrals, because as you can appreciate, we get a lot, and if an assessment takes a day, we're clearly not going to make that if we assess everyone that comes in our books. So once someone is known to us, we may not necessarily go out and see them again in their home for quite some time, but we will do reviews. So we can do a lot over the phone once someone's known to us. Or if someone goes into hospital, we might look at the notes, talk to the staff and various things, and we can do a lot that way versus going out to their home and doing another assessment. We work very creatively because we have to. And so, yes, if someone's known to us, we will help them, but we will work creatively and may not go and do that assessment as they're expecting. It's just understanding a lot of people are waiting for us to turn up at their door, and we might not get there, but we might be calling them. And I think that's probably about it for the services, yeah. I think so. How to refer, quite straightforward. I think everyone knows this, but for GP practices, health professionals, if you've got, I call it RMS, on the other side, I think it's HealthLink. Yep. So we're under there, but you will find us under older person's health, because that is just how we got set up a long time ago, and that's not going to change. So don't look for NASC, look for older person's health. If you forget, no problems, because I think there is a lot of people will come through the community allied health tab. Just put NASC in the title and we'll find you. But if you can look for older person's health, that's the way to go. The other way to go is you can emails, happy for emails. So generally health professionals and health, anyone that's got the e-referral system, that would be our path that we would love people to take. But obviously not everyone has that, so we always have an email. So people just email us direct and we will connect via email that way. And basically we also have an 0800 number that people can call us, and that's for our clients, and anyone can give that out. Like I said, all welcome to have our phone number. Anyone can call us whenever they need us. All right.
I guess just probably the big thing to finish on is, like, you know, we do have a wait list. It's, you know, it's as good as a wait list when we sit on a wait list, as good as the information we receive. But if things change when people sit on a wait list, so if you are finding that there are significant changes and we need to act more quickly, just come back at us. We're always happy to receive further information and relook at any previous triage and reprioritise.
And a big thing too, because we have a lot of stressed clients, a lot of stressed carers, and totally understandably, and they hear about our wait list. It's not about what position you are on our wait list. It's not that you're the 100th. You're going to have to wait to 100. It is about need, and so it's about just reassuring. It's not about they've only just heard your referral. It's about what's going on with that person, what the need is. Are they living alone, family, whānau, all those other things that come into play. So it's just sometimes reassuring them, because we get a lot of stress carers in clients.
That's why we now have 3 people sitting in triage, so that we can reorganise as we need to.
Yeah. So, and just to put it, so we do have a criteria for an assessment. So when we get a referral, it's a criteria for an assessment, right? So just to put in perspective, it is about a personal care need. And that's not necessarily the person can get in the shower by themselves, so they're not going to get NASC. It's a bit more than that. So, this way? Yeah. I really need to be seen. I'm okay about it. I don't think anyone's listening. But yeah, so basically, it's a bit more than that, but it is people that are actually struggling to manage in the shower by themselves. Mobility is an issue. There might be incontinence. There might be like dementia, cognitive impairment, high care of stress. That kind of includes that. So it's just to put that in perspective. And we do get, and it's not about, because often we'll hear, oh, well, they don't have a personal care need, you won't get them, or someone does have a personal care need, but they've chosen to decline supports, and that is their right to do. We have a lot of people out there that actually do benefit from personal, for our help, but they don't want it, and that's their call to make, but it doesn't mean they don't meet our criteria, that they're not part of our system. So it's just understanding that difference. Home health is a big topic. So how's that household management? So we're personal cares, so that's your shower, your everyday, your personal cares, and then there's home health, and that's, in the nicest sense, essential housework. And I say essential because it's not the whole house, and it's not your spare 4th bedroom, and it's just your living areas, your personal space, your kitchen, the things that you use every day. There's a criteria for that. Clients must have a community services card. So that's always a good start. No point asking for it if they don't have one, because that won't change. The other thing is they do have to have a personal care need. All right, so it means we would have had to assessed, and they do have a personal care need, and we will allocate home help. But if we assess and they don't have a personal care need and they don't meet that, then we're not getting home help. Does that kind of make sense from that perspective? We have to factor in if there's an able-bodied person in the home. So if you do have a community services card and you do have a need, but you live with your daughter in the same house, you're potentially not going to get home help. All right, so we have to look at all those things, if that makes sense. So, yeah, people can get a bit confused about that, but that's pretty much how that works.
I guess the only other thing too is when you are, like I had a referral today for somebody for home help, personal cares, lawns, outside house maintenance, things like that. We are inside the house only, so that's what disability allowance is for anything alternative. Yeah,
so that would go, they could go to WINS. If they're asking for lawns, direct them to the WINS aspect, and that, and it's just because I think we all know that, isn't it? People get so many different messages out there, and so then they wait for us, and then we get there and we're like, oh, you don't get what you've been waiting for, and it can be really frustrating. So if we can give advice and help them sooner rather than waiting, it's just alleviates people's stress. Be great. And I think, is that one that's our side, right? So, oh, look at that. Oh, no, is that Maine? Is that us? No. Is it? No, that's not us. Sorry. Clearly, I didn't decide.
I think it was the expression.
Was
I
Qualify for ACC, not us, leave it to ACC.
Oh, is that us? Oh, that's fine.
Of course, Northable, those under 65.
Just clarify the mental health. Mental health, they do sit under us, depending on their age and the situation. So it's not we don't exclude all mental health, absolutely not. What that's just saying is, if it's solely mental health, pending their age and the situation, that there is a mental health NASC, but they do slightly different things. So when that need changes, we may step in. So for example, mental health under 65, they don't support with personal cares or anything in the home, so they won't do that side. So that might be where we come in, if that kind of makes sense. So we do support mental health clients, absolutely, but just not the situation. But yeah, that does. And who else wouldn't we? Yeah, ACC. That's about it, really.
Yeah.
And we don't have any special connection with ACC, unfortunately. So I think we have a lot of clients that cross paths with ACC because they've had ACC, and then we might need to step in after ACC, after an injury and all that kind of stuff. And I can appreciate that can sometimes be really confusing for clients trying to understand how that works. We don't have any other ways to contact ACC is ringing 0800 and finding out when their C status, what they're doing.
What she's saying is we'll spend 2 hours on the phone waiting for ACC.
Just like everyone else. And I would love that to change. You know, I definitely would be, that would be so good, but I'm not winning that battle at the moment. So it's just bear in mind, and it's a big thing because ACC and all these things we're talking about, as you can appreciate, can be so confusing for clients and family and whānau. So it's just, we do get it, but unfortunately there are some things we can't fix or solve. But yeah, cool. Any questions?
Enough time.
Is that us? Boom.
Thank you.
Thanks very much. So once NASC has done their determination, then we receive the referrals. I'm going to just take you briefly through what happens when we receive those referrals. So we verify that we can actually service the area, that we have the level of qualification of support worker needed, and that we have available support workers in that area. We then respond to NASC and we respond to the client that has been referred to us. We tell them we will assign a nurse coordinator who will visit them. One of our nurse coordinators will visit the client, they'll do a hazard plan, they'll do a care plan, and they'll develop it in conjunction with the client. Once they've completed that care plan, they will go back to the office and liaise with our service administrators to see when that care can be done. And then we start dealing with difficulties such as everyone wants their morning care at a certain time, and we only have so many support workers, and that 8 to 9 spot is really popular. So there are a couple of things we have to actually work with, and it's good to be aware of that. That is the same with any other provider. The early morning and early evening is a very popular time, so it's one of the things to be conscious of. But we do whatever we can to accommodate the needs as defined by NASC and as defined by a nurse coordinator when they visit. Our support workers are then assigned to the client, and there's a roster. They are in contact with us via apps, and we get feedback from them in terms of the visits that they do. They're our sort of first line of feedback as well if anything changes. So we train them and we communicate with them all the time to come back to us with anything they notice that is different from before. They get to know their clients pretty well. So we'll generally, with our permanent support workers, we'll keep them with clients as long as possible. And the only time that we'll change a support worker out is if they're on leave or sick or something similar. We have a group of relief workers that will step in that time. They're equally trained, but they may not be someone the client is used to. And sometimes that can create issues for us, but it's one of those things that's really difficult to get around. We communicate with the client when we make changes, and the support workers that go in as a new option, they're also aware of it, particularly in our higher care clients like with dementia. see. So we train our support workers in a variety of to work with a variety of conditions, and the basic induction covers all the basics of manual handling and lifting, and everything around personal care and home care. But then we do have additional training, such as the support workers working with dementia. There's some working with different conditions, and we provide training for them to be able to provide the highest level of care for that as well. We also collaborate with connected services. So again, if our support workers pick anything up, they'll go straight back to the nurse coordinator who's allocated to that client, and they'll advise that they've seen something. The nurse coordinator will then decide what is appropriate. That can be anything from contacting the GP, social worker, mental health worker, depending on what the situation is. They'll talk to you guys as well. So they bring that information back, and the nurse coordinators will then do what is necessary. And that, in a nutshell, is what we do. I wish it were as simple as short as it was, because it certainly isn't, but that's what we do at Home Support North, and we absolutely love what we do. That's why we supported this evening. So please feel free to indicate that to any of your clients at any time. And at this point, I'm going to hand over to Satish from Northable.
Hello everyone, my name is Satish and I'm from Northable Equipment. Just want to give a little bit brief about Northable. So Northable Disability Services and Northable Equipment. So I'm coming from the retail shop. I'm the manager over there, and we are a non-profit organization. So whatever the profits we make, it goes towards the community. So I'm here to present what are the tools, some of the tools which are essential for the individuals who are suffering through the dementia, which could be helpful for the carers as well as the patients. So a few of them I have here, starting off with walking frames, walking aids, rollators can be called. This gives a bit more stability to the individuals, risk of fall prevention. Same thing with wheelchairs, which gives more stability, safe to transport, and that moves around. The next thing is the motorized lift chairs, which helps the individuals standing up and standing or sitting down. Now, not only that, but also with the individuals when they have communication issues with the communication, where they have trouble in having a conversation with the carers. That's something which definitely helps them lifting them and moving them around. The next one is the memory aids, the cognitive impairment rates. This is something which helps the individuals where they can press the particular device which shows the large display unit where it can touch, where it can also talk about what's the time, where they can't see, which also talks to them back to them. Yeah. So there are some devices which will be really helpful for day to day, which talks about what time, what's right now, whether it's a day, morning, or afternoon, or it's the evening, because that's what important for the individuals to keep tracking what point they are at the moment. With few other devices such as tracking devices, this is something where patients can be tracked by putting the tracking devices like a pendants, or even can be used on their clothing, which gives the location to the carers. They know where exactly the individual is. Same thing with the bed alarms. When they try to attempt to get out of the bed, that gives the bit more notification to the carers. Same thing with the fall prevention devices like non-slip mats, which can be used in the bathrooms and kitchens, which gives a bit more safety towards for the individuals fall prevention. Same thing with the grab rails during the shower, which can be used in the bathrooms, where it gives more support for the individuals to get in and out of the shower. Communications, there are so many devices coming up with the technology has been increasing with the larger buttons, whether it could be the cordless phone or could be the one with the wire, where they have larger buttons where they can see and can also put pictures in it where they can dial in who they want to contact. Personal care equipment, as I talked about, the shower chairs and grab bars, which gives more safety while they're having showers. You have shower chairs, which could be stools as well, with swivel chairs, where it gives more safety towards the individual while is moving in and out of the showers. Grab bars, again, you get in different types, which gives more safety towards getting in and out of the showers. Same thing with the toilet seat raisers or toilet seats, where it gives a bit more stability in and out while sitting in and out of the toilet. And there's so many tools, such as for dressing, where you're struggling with zip hookers, or it could be the button hooks, and even for the pant, where you can pull yourself up. But the procurement side, it's just that giving the individuals to try find the proper supplier, what type of equipment is available out in the market. With so many suppliers now available, you can see what they have included in it, what kind of technology is included in it. And when it comes to the purchasing, whether it's to the funding side, again, there are organizations like Hauora, or this ACC, or Ministry of Health, or the main thing is events as well, work and income, applying for funding. And this all includes with, obviously, for delivery, setting up, or anything like that, and also training, which individuals are looking after, like caregivers or people, just to give it more training towards when they get the equipment. I think that's from me, I guess. If you have any questions, feel free. I'll pass it on to Ona.
Brilliant. Kia ora guys, my name is Omar. I'm the manager at Unichem Pharmacy. I apologise for my appearance. I came straight from work, 7 days in a row, 12 hours a day, so been a bit of a busy time, but we'll hang in there for this presentation. So I'm going to talk to everyone about the importance of adherence. Now, we all know what adherence is, but in pharmacy, we define adherence as taking the right medication, the right dose at the right time. And that's really important. In the case of a study done for a 65-year-old gentleman who has a high risk of cardiovascular disease, if they were to stop their blood pressure medication, Northable, their blood thinner, aspirin, and their cholesterol medication, atorvastatin, for a period of 3 to 6 months, they increase the risk of having a cardiovascular event by over 40%, which is significant. If they were to have a cardiovascular event, such as a stroke or a heart attack, their all-cause mortality goes up over 5 years by 50%, which is a significant amount. And imagine this is something that we can prevent. But that also leads to two problems. The first problem is the strain that it causes on family. And it's selfish to say, but unfortunately, everyone has lives, everyone's working, everyone needs to get through. And it takes a lot out of the family, both emotionally and financially, to be able to care for that person. The second thing is, it puts a big burden on the health system, both physically and financially, especially for something that we can prevent. So just to give a bit of an example is my own mother. So 15 years ago, my mother was diagnosed with Parkinson's. She was started on a medication known as Cinemet, which is meant to treat Parkinson's. Unfortunately, over time, her Parkinson's progressed. So she went from 3 times a day to 4 times a day to 5 times a day, to the point where the specialist basically said it's not enough. We need to increase something more. We had 2 options. We either go for surgery and we go for something that's deep brain stimulation, which is a probe which is placed into the head, or we go for a subcutaneous injection, which is an injection that needs to be done every single day and needs to be inside the belly every day and changed every day, and she uses consistently. After the 5-year mark, we decided to go for that. Now, looking back at the time, we realized that we started that medication far too early. And we didn't realize at the time, but my mother actually had dementia. She seemed normal, just like they talked about, right? 15 minutes, they're fine, fine, the children are fine. But actually, she wasn't taking any of her medications at all. So her progression was the fact that her medications were not being utilized. She wasn't taking them. Now she started something, which unfortunately we can't go back on. And because she started it early, her Parkinson's has progressed further, and there's only so much of the apomorphine you can use. Now, in my mind, I think to myself, if only we had some form of tool, right, at that point in time, who knows the situation of my mother? Because right now she can't get out of bed. Who knows? Maybe we would start apomorphine now. Should have been fine, but who knows? We can't take back the past. So that takes me on to the next point. Blister packs. All right. So we all hear blister packs, but what are they? Essentially, blister packs are bubble packs. All right. They have the patient's name on it, right? They have the medication the patient is taking on the back. They have the date of the medication, the dosage, the time, and what medication is, and when to start, right? We set up a pack for a patient. If they're on multiple medication, whether it's morning, night, dinner, doesn't matter how many doses, we'll get the pack started, okay? Let's say in this case, it's morning and night. I've got 2 packs here, right, for morning and night. Today is the 8th of the 5th. They'll start the pack today. What it does is it creates a visualized representation. Have they taken the medication or not? It allows the family member to help to administer the medication. So that way we know, have they taken the medication or not? Whether it's a caregiver, whether it's a support worker, it allows them to also know, has the medication been taken or not? It makes life easy for not only the family, the caregiver, but also the patient, right? And also the GP. If we had this at my mum's time, who knows what would be in the situation. So this is something that very simple, but very important. I'll hand those down for you guys, and you can pass them around. All right. So these sometimes, depending on the need, especially when they're looked after by caregivers, we pair with what's known as a signing sheet. A signing sheet calls for accountability, right? So what happens is a caregiver signs off the signing sheet that at this time I gave the patient this medication, or will they give this medication? So it's kind of like a crosscode. So let's say you have a caregiver at home and you want to follow up on your mother has the medication. You just check the signing sheet. Another easy way to make sure medication has been started. All right, you can pass that around too. That's right, Satish. So we've talked a little bit about blister packs, but what's the cost? How do we set it up? Very, very simple. What happens is a prescription comes through from a GP, hospital, whatever. For us, we get a lot of referrals from the hospital at 7 p.m. at night on a Sunday or a Saturday, and because we don't believe in telling people we can't do that. We can't do that to anyone, and we do that completely free of charge. We don't charge anyone for their medication. We don't charge anyone for their blister packs. That's fully free, and that's not something that's subsidized. We take that cost on of the blister pack ourselves because we believe it's important that everyone can have their medication, especially if they need it. Really, really important for us. So it doesn't matter the time. We're open 8 a.m. to 8 p.m. and we do this 7 days a week. Christmas Day we were open. I had 5 blister packs, and we were the only pharmacy in town. In all of Northland, we're the only pharmacy in town. Still did it. Why? Because of the need. People can't manage their own medication. Enough about blister packs. I'm going to move on to something else which is really key and another function that we do, and we work with a lot of we work with caregivers and we work with a lot of residential care places to help managers, and that is three-way communication. This is something that is really, really, really important, and we don't understand how important it is. The first thing about three-way communication is it allows for the patient to be able to communicate with the caregiver. Caregiver communicates with us, right? A lot of the times, patients are afraid to tell the doctor, right? Or they don't want to bother the doctor. I've literally heard, oh, I don't want to bother them. They've got so many people to see. But they don't realize that it's never a bother. We're just helping to care for them. But we'll hear it. Example is a couple of weeks ago, I had a patient. She was telling me, oh, I just had a fall. I said, what happened, right? And the caregiver was there, and she was explaining, yeah, it's not first fall. We discussed, we looked through the medication. We realized the patient's on diuretic. The patient's about 85 years old. Probably there's no place for the diuretic anymore. We rolled with the doctor, got her off the diuretic. Guess what? She's no longer waking up at night time, no longer falling. That shows you the importance of three-way communication. And as we all know, as health professionals, right, or within the health field, if an elder person has a fall, right, if they have a fall, there's an increase of a hip fracture. And we know that an increase of hip fracture increases the risk of all-cause mortality by 60%. So it's not a small factor. So three-way communication, really, really, really important. And not just for the sake of the presentation, but for individuals, I stress this enough, wherever you are, in whatever role you are, whether it's communicating with the pharmacy, whether it's communicating with a health professional, important to have that dialogue. Whatever you notice, it's important because it can make big changes to the life of that individual, and you may not realize it. All right, guys, that is me. If you have any questions or any questions to anyone on the panel, please let me know. Thank you.
I have one question, sorry. The blister packs
Yes.
and the, I can't really think of the name, but some that struggle to open the blister
Yes.
pack. You've got some little device.
Yes,
that,
we do.
yes, you do. Eh?
We do.
That's I'm doing it right.
Brilliant. So we have devices. So for the blister packs, that is a very key point. So the reason the device we have basically is a device that when you press in the corner, it would just take a light bit of touch and it'll break the pack and it'll open it. So that's one thing we do, and they're called blister poppers. So we provide people who have arthritis. We also have another device that we provide with them with, and that's only if they really need it because they are costly devices, but we obviously provide it from our own pockets. Where they can press it onto the foil, just a light press, and it will open the foil, and all they do is slight twist, and the foil will come away. So for people who are administering by themselves, definitely these are something that we give, we promote. And another reason why we use, just because it's gone on topic, we use blister packs over those bubble packs, is blister packs are a bit more expensive to use. However, they're easier to visualize. Those bubble packs, if you've ever seen the bubble packs, they're basically little sachets and they get rolled on each other. They're very confusing. Imagine, because what happens is, if they go out of sync, you don't know what date is what and who is for what. And so many of our patients that we look after are on variable dosing, and that dosing, the dosage time matters. And as I said, we talk about adherence in terms of right medicine, right dose and right timing. So with those kind of packs, that wouldn't be it. So that's something we could have done, but we've decided not to take the extra costs and do it right because unfortunately, if they come unraveled or, it would cause a bigger problem. So, yeah. Any other questions, guys?
I'll see you tomorrow for one of those opening things.
Yes.
Is there anything that we can do for like patients that are on injectables like insulin or any other injectables as like a reminder for them to take them?
That's a great one.
Like have the blister packs for their tablets, but not the.
That's a bit of a hard one. So
Yeah.
that would be where I guess you set up reminders, right? So stuff like that works with Satish, Satish would be able to help you out with that in terms of setting up reminders. I guess items that tell you, remind you to use that, whether it's setting up reminders at home for them on a phone or something along those lines, which tells them, hey, this is your time, an alarm, this is your time for your insulin, right? But that's unfortunately something that's a little bit out of our scope, and I think Satish would definitely be able to help you out along those lines. The devices help with that.
But it's definitely something that you would refer to us if you've got someone with cognitive impairment or dementia. Who is prepared.
We do.
Yeah, because there's some people that can't do it physically, but there's some people that safety-wise, so you can come to us. And we probably should, because medication administration from a support provider is a different topic again.
Yes.
There's limitations to what we can do. So, but definitely anyone with cognitive impairment, dementia who needs medication oversight, we would come our way. Yeah. Yeah, then it will go your way, and then it will go your way to get the blister back. There you go. Yeah.
What a team.
I'll hand you over to Matt.
Thanks. Just before we finish off, just want to make sure there's no other questions. Anyone else? Any of the speakers?
No questions online that I can see, unless anybody here has any more questions.
Great. Well, thanks very much for attending. I hope that you guys got some really worthwhile things out of it, out of the questions and the presentations. It certainly seemed that way. Thank you for arriving tonight. Rachel, thank you very much for organising from Mahitahi side, and we look forward to seeing you again at another one sometime in the future. You do have one.
Edit there. We'd really like your feedback. If you can do the survey for us, that would be amazing. There's also a question on there for if you want any other topics, please let me know and I'll do my best to arrange them for you. So hopefully that's incentive to fill this out. Yeah. Oh, on the back of your paper, there's the QR code. So
I've got it now.
You can either scan the QR code or type in that link. But yeah, that would be really good if you could do that. Thanks to all of our presenters tonight. You did a great job. So much information in there. And we will be sharing the recording out, so we hopefully get more viewers of that as well. So I will just close up with a karakia, and then you can all go home. Whakamoa te korero, whakamoa te wānanga, whakamoa kia rangi nui tu ihone, whakamoa kia papatuanuku e takoto ake ne, whakatina ki te tuma o te maramatanga, kia tina, huie, hai kie. Okay. Thank you all for your time tonight. Great job from the speakers, and thank you to our audience as well.
Thank you.